Thank you, Dr. Saurabh, and thank you, AIOS and APO, to give me this opportunity. This talk is, I'm not expert for this, but I am learning also together with this. And while I am preparing this talk, I realized that many of the things we can do, but I was not doing. So basic thing is why premium is required. It is we all doctors deliver quality, but we want sustainability and we want to meet the expectations of the patient. And the patient expectations are that they are going to have the best, but cannot be done in a all cost. So there are schemes which give very low payouts. There are schemes in which they have limitations that you can't do this, that, and other things. But we as a doctor are bound to deliver the best. But to deliver the best, if it is coming a cost to us, we have to maintain two separate streams in which one is by the schemes or one is by the premium. And this premium segment is going to make your hospital survivable, and the schemes will give you some footfall which you feel happy because the patients are there. But if you do some audit, you will realize that you are actually not doing what is required. But before entering into something, you should do audit of your own patients, that how many of them are through schemes like CHS or the government schemes or the empanelments or insurances or some other schemes you have taken for which the patients are being referred to you, but the surgical charges are limited to a very minimum. Like just for an example, I would say the CHS charges are 9,700 for a routine and 11,000 for a NBH. But for these, they include everything: pre-op investigation, admission. They expect the food also, but luckily we are having a daycare system in which food is not to be served, but otherwise in the same charges you need to give the food also, and the post-op medicines and the post-op care also. So we need to divide one thing. We should know our own system in which how many patients are from particular stream. So that audit is a must. Then we have to define what all we can actually offer. You may be doing cataract, as presumably we do 90% of the ophthalmologists do cataract, and majority of the work comes as a cataract. But if you decide, suppose you are a retina specialist, you are a glaucoma specialist, or any cornea specialist, whatever. So what are the things you are going to offer? The offer may be means different, that is not available in your locality, or you want to do something which is not commonly done, or you want to do something in which the upgrade is there by the way of technology or something else. And these upgrades should be a stepwise. It should not be like this: you open a high class center in day one and you are not able to survive it. So it should be there, and what all you want to do should be communicated to your staff and to your patients also. And at the end you should monitor the outcomes in a financial metrics also, which I was not doing at all, but now I think I will be able to start do it. And this is the most important matter which we doctor forget, that we are working almost without salary. I am talking about the people who are doing their own setups. They never ever think that they should be paid, and because their home expenses are made out, they are feeling they are doing good. But when you compare yourselves with the doctors working in a corporate or government setup or something in which they receive something every month, and that difference you are not putting into your own practice, should also be considered into this. So after that you will understand what is the thing. And the second thing is that whenever you try to shift to the premium practice, you cannot do volumes. If you are able to do volumes, then you are lucky and you are master. But if your volumes are not good enough, then you need to maintain something like the footfall, as I said in the beginning, to have the patients who are coming through the low payouts also. So you maintain some patients and then convert them. You build your own name. You have your own number of particular threshold patients to whom you have done surgery and they are happy. And that threshold level, once achieved, the patients will come and ask you that I want something extra or better or different than the government schemes. And that is the day when you are going to start your winning. Like the same thing started when the laser surgery came into for refractive surgery. People started having a LASIK OT, a premium, what you say, waiting, premium operation theater and other kind of things. Though the kind of more skill and more, you say, stringent parameters are required for the safety into cataract. But people were, because LASIK was new, so it was routine, it was different from the routine practice, so we become cautious. The similar way we should be cautious for the cataract surgery or for premium cataract surgery. When you try to divide them into government schemes, low income, medium income, you need all kind of patients, and your center should not be, or your hospital should not be known that you are just dealing with the premium patients, you are dealing only with the government schemes, because both are damaging. Both are damaging. So you need to decide what way you want to go slow, but it should be in your mind. And to give a premium experience, which corporate people are ready to give, and it is good for us that now we can learn from them. We all ophthalmologists having an initial single person setups were never ever thinking that these kind of things are very important, that how the ambience should be, what should be the patient flow. If patients are waiting, we are happy. If patients are not there, we say, oh, it will not be there, not today, but it will come tomorrow, or there will be a season times, so we will find excuses that because of this season we are not having the patients. So that also should be in your mind, that what are the days when you have, what are the days means it cannot be by the dates, but we know these are the reasons that the March and December are having a high output for the surgery, and the May, June they are slightly low. Particularly I am saying in Rajasthan, it may be different in the different parts of the country, and you need to do something for the branding. But my most important thing is that it should be consistent. The consistency is there in for many things. Consistency in your surgery, consistency in your behavior, consistency in your pattern, consistency in your like if you are growing every year, that should be there. Consistency should be there, that the people who are there working for you, there should be low attrition, they should be working for you for a longer period. That also patient likes, that I came 4 years ago, the same staff was there. Though the staffs may be upgraded, which is not common in routine practice, or people I work single or in a group of the people who are working, but in corporate setups you see that somebody was sitting on the reception, now is a center manager. So these kind of things patient notice, and they realize that this is a center which is growing. So they have different things which are there. The similar way you should back up your own system in which you have a something to support you. It is not only hands by which we get the results. We get the results by the best diagnostics, best equipments through whom you operate, and best of the follow-ups. Best of the follow-ups does not mean that the patient comes and say, and some trivial complaints are there, and we say, no, kuch nahi farak padta, it will be okay because my name is there. No. For everything you should find an answer, and when you know why it is happening, then you will grow. So for that I use the term medical and surgical audit. Whatever drugs you are prescribing, if patient comes and says on your pharmacy, sir, I was not happy with this drug, there was something different than the previous drug, though they are having the same component, then you should not write that drug also. So same way there is a surgical audit. Surgical audit means you have implanted something and it is not delivering what they have promised or what you expected, then these kind of things should go away. There are particular lenses, all are good lenses, no financial interest, but whatever you feel is giving better results should be taken into the thing, then your premium practice will increase. Otherwise you say that this lens is slightly 10% cheaper or something like that, or they are bundling up me something. Don't use them just because of these reasons. There are different reasons of financial viability, there are different reasons of surgical viability. So your concern should be mainly for how to deliver what actually you have promised. And the quote is that always under promise and over deliver. So those kind of things you need to know by feedback, by surgical audit. And whatever results you have achieved, you should be ready to publish. And once you publish them, you get more enthusiasm as well as confidence into it, that what should be done. The counseling should be actual, it should not be a sale. It should be counseling, means you are just giving information. And patient should feel that I have been added with some knowledge, and my idea of getting, like suppose we do monofocal, advanced monofocal, multifocal, EDOF, or whatever variety of lenses, whatever he choose, but he is aware about everything, that is the important thing. If he is not aware, then next time he comes and says, so I wanted that, but you have never offered. So I feel we should offer everything to him, though it takes time. Sometimes they say I am not interested into listening, but just say very politely that you should be aware about it to take a decision, it will be a better decision. And tailored pricing model means it should be competitive, but it should not be like just for the sake of saying that he is charging so much, so I should do 10%, 5% reduction. It may not be maintainable, sustainable, and then it will be a problem. And costing should be transparent. It should be one and same for everyone. There are places I have seen that after seeing somebody they say it is this much, and after seeing somebody else they say this much. You can offer a discount, that is your right and their duty also. Sometimes because of some knownness, some people are not affordable, or there is some reason that you want to give some discount. But at the same time you should be able to charge extra for the like cases who are black, posterior polar, subluxated, these kind of things. It cannot be like this, all catheters are having the same pricing. So you should have your own system, and it should be known to you, your team, and your patients by a transparent manner. That is the way to go ahead. Now the things are there, should we do or not do at all the government system. you need to do a government system also, because there are sometimes it is binding that you need to have this kind of system. Like I have heard about some states where the government is making that you need to do AIOS for sure, and there are states where it is not compulsory. We are lucky in Rajasthan it is still not compulsory for particularly cataract surgery, because we found that when we took a decision, and here comes the role of society also. When I was the secretary of the Rajasthan Ophthalmic Society, somebody called me up, Virendra, वो भामाशाह scheme आ रही है and you are not empaneled with the cataract surgery for private setup. So I immediately jumped. When I called my treasurer that we have to go and fight with the government. He said, what are you doing? Why you are doing? I said, somebody has called me that why your cataract is not included. Then he said, think for the matrix. Is it going to be useful? Then we realized, and we went there, and we said that cataract should not come to the private hospitals for the reason because it will not be survivable and we will not be able to do justice, and you will not be able to do audit that cataract is done or not done. And the government said, yes, we will not keep the cataract into the government system. And since then, for almost 10 years, we are happy and lucky that we are not having these schemes into cataract into Rajasthan. So that is a survival. So these kind of things you require to understand, and I again say the society has to come forward. We have to strengthen the society, and society has to get load that whenever the something is going to be a suffering for a members, they should fight for it. I was thinking that Dr. Partha and Namrata will be here, so I will be able to convey my message directly to them. But for their engagement, they could not come right now, and I have to go for some other session, so I will be leaving in between. I requested Saurabh, and he adjusted me for the talk before time. Thank you very much for this opportunity. And I invite you all for the next conference in Jaipur of All India Ophthalmic Society, AIOS2026, into Jaipur, 84th Annual Conference of All India Ophthalmic Society. Thank you very much.
Thank you, Dr. Virendra Agrawal, for your very nice keynote address. You are very right. There are certain things which cannot be done in the private setup. I know that their empanelment, when I was in government sector for 42 years, I joined an institute which is already, I think, existing institute, no issue for me. But I found that there is an empanelment of ECS, ECHS, CGHS, and other patients. Recognition is important for that. And there are also these government scheme, because in the government hospital they get subsidized because they give lot of support including infrastructure, operating microscope and everything, even phaco machines to the government institute, whereas in the private you have to earn. So I think whether if it is not cost effective, we should say no, as you rightly said.
Sir, what you are saying is correct, that we requested society, and society is trying also fast, but AIOS should get what you say return on investment of the government sector. And you will be surprised that the cost of surgery in cataract, in setups like PGI, AIMS or any other government institutes will be to the tune of 25,000 rupees.
Yeah.
And for the government schemes they say 9,700 rupees.
Yeah, for private they will say so, do everything within 8,000, 7,000.
And
7,
they have to have their own doctor, staff and ESI,
no,
PF.
it is difficult.
The land, equipments, and they are asking every time again, bring this equipment. 4th generation phaco machine they write without knowing what is the 4th generation. So they say the need is a 4th generation phaco machine, you need to have OCT, you need to have YAG laser and so many staffs also.
Another issue is that although there is no, in the keynote there is no question, but another issue is that while you go to private practice or private setup, you have to tell patient everything, that this is this type of, what type of prognosis, truly you have to tell that there is a, say macular edema is there in diabetic. So you have to say that you will get poor vision. Whereas in the government setup, you will get away with it.
So what you are saying, I have put the other angle. You need to do OCT before each cataract,
no,
and that is not paid in government scheme.
No, we do in every case. But whereas in the government setup, we were not doing.
No, you were not doing, and it is not paid also. In private setup, it is said that you should have done it.
Yeah.
And will not
surely
give payment.
We have to otherwise do it.
Yeah.
So thank you so much for your nice keynote.